Diet and coronary heart disease. It's a common misconception that eating fat makes you fat. This chapter evaluates various studies related to dietary, ecologic, and cultural factors to assess the validity of the classic diet-heart hypothesis, which suggests that a diet high in fat can lead to high cholesterol, plaque formation, and ultimately coronary heart disease. One of the most influential ecological works was the study conducted by Keyes et al. The study was responsible for linking the mean intake of dietary factors from 16 defined populations in 7 countries to heart disease in the same groups. Coronary heart disease incidence rates were strongly correlated with the intake of saturated fat. Countries that showed a lower incidence of coronary heart disease and saturated fat intake happened to be less industrialized. The sample populations differed in physical activity levels, obesity, and smoking habits. Finland had the highest fat intake, and Crete had the lowest, but both populations had the highest rates of coronary heart disease. This shows that there are other factors, such as obesity and physical activity, that can influence the progression of coronary heart disease. A migrant study conducted by Cato compares coronary heart disease incidence rates in samples of 45 to 68-year-old Japanese men living in Japan, Hawaii, and California. The saturated fat intake as a percentage varied, and the mean relative weight and serum cholesterol level differed in parallel with saturated fat intake. The dietary cholesterol was unchanged by alcohol. The data in this study indicates that genetic factors cannot explain the substantial differences in coronary heart disease rates in 3 different areas. California was almost 50% greater than the other 2 groups, suggesting that these are environmental factors rather than genetic factors. Studies of blood cholesterol as an intermediary factor between diet and coronary heart disease are considered in 2 parts, relating diet to blood cholesterol and relating blood cholesterol to coronary heart disease. Relationships between dietary factors and blood lipid levels are best done with randomized small control studies. Many studies have shown that higher intake of dietary cholesterol and saturated fats, along with lower intake of polyunsaturated fats, increases total blood cholesterol levels. The studies have also found that substituting carbohydrates for saturated fats raises HDL cholesterol in proportion to the increase in LDL or total cholesterol. One study used an intervention trial to evaluate the risk of coronary heart disease using serum cholesterol levels. It can be useful to assess serum cholesterol, but it is better to look at LDL and HDL independently. The risk of coronary heart disease will increase with higher total cholesterol levels, but will increase even more with low levels of HDL cholesterol. Other factors to consider include alcohol, estrogen, obesity, smoking, exercise, and medications that can affect coronary heart disease risk. One major study that provided reliable findings on diet and coronary heart disease was the Costa Rica palm oil study. The study examined the relationship between palm oil consumption and the risk of coronary heart disease. Researchers used subcutaneous adipose samples to analyze fatty acids and carotenoids that can reflect long-term intake and are unlikely to be affected by acute events. The primary finding of this study was that palm oil used in cooking was positively associated with the risk of coronary heart disease. Prospective studies eliminate biases related to selection of control subjects and the recall of past diets. Many limitations of older prospective studies have been assessed to make for better consistency. Newer studies often use summarized pools of analysis of the original data. Researchers know that the degree of variation in data amongst participants can increase or decrease the possibility of finding associations between diet and coronary heart disease, and that larger studies are more likely to see an association between diet and coronary heart disease, though they may still have issues that can be difficult to resolve right away. Investigators have used biochemical analyses of plasma lipid fractions, platelet or red cell membranes, and subcutaneous fat as an alternative to measuring dietary intake, as these are all markers of fatty acid intake. These biomarkers can often provide information that may be difficult to obtain from a questionnaire. An example of this complex dietary information can be the type of fat used when cooking and the degree to which it has been modified by processing. A case control analysis can be used when collecting blood specimens before the occurrence of coronary heart disease. Unfortunately, the percentage of a fatty acid in a sample is affected by changes in other factors, such as endogenous production, making the levels of major saturated fatty acids in the body weakly correlated with intake. Randomized trials determine changes in dietary lipids, reducing the risk of coronary heart disease. 2 general strategies have been used, such as replacing saturated fats with polyunsaturated fats and carbohydrates. In early trials of coronary heart disease prevention, patients received modified diets. Cholesterol intake was reduced largely, and intake of polyunsaturated fats is increased by 20%. In the Finnish study, coronary heart disease rates were reduced on the modified diet by 51%. Despite limitations among studies, many more have shown correlations between the decreased risk of coronary heart disease using diet modification. One major component of the diet-heart hypothesis includes a relationship between blood lipid levels and coronary heart disease risk. More research is needed to identify which subtype of cholesterol is impacted by diet, and thus how that relates to coronary heart disease risk, as well as how the body responds to and metabolizes specific sources of dietary fats. There's a greater need to understand the impact of diet on blood lipids beyond the relationship between diet and total cholesterol to consider genetic predispositions to high cholesterol or coronary heart disease and long-term aggregate impacts of diet on the risk of thrombosis or abnormal heart rhythms that can cause heart attacks and coronary heart disease. There are many different types of fats, and each can have a different impact on coronary heart disease risk. For instance, we know that high consumption of trans fat and saturated fats can increase coronary heart disease risk, while polyunsaturated fats can have a positive impact. Within the category of saturated and unsaturated fats, individual fatty acids can also have differing and specific impacts. However, additional research is needed to identify an optimal intake of polyunsaturated fat sources to understand the impact of oxidized cooking fats and to link specific foods to coronary heart disease risk. Mechanisms such as hypertension and excess body fat are contributors of coronary heart disease. Strong evidence shows that moderate alcohol intake and higher intake of fruits, vegetables, and nuts will reduce the risk of coronary heart disease. Despite needing additional research, carbohydrate quality contributes as well. Increasing whole grains that are high in fiber has been shown to reduce the risk of coronary heart disease. The research summarized in this chapter suggests that there are many factors that contribute to coronary heart disease aside from fat intake. Further research is needed to determine dietary guidelines and recommendations for effectively reducing the risk of coronary heart disease.